All right, apologize for the delays here, everybody. It looks like we're getting everything squared to go, so I will go ahead and introduce myself. My name is Mike Hess. This is COPD Navigator Live, a weekly look inside the world of COPD with some of the new, latest news topics coming out. Plus, if you're new to the show, we have about a half hour's worth of educational stuff, and then we do your questions and answers live at the end of the show. Again, we do this every week, usually around noon Eastern time. So if it's your first time joining us, please feel free to stop on by. You can see below here we have a link to our Facebook group, COPD Navigator. We also have a brand new Facebook page that should be streaming through, and everything should be working okay through that. Might be a little bit easier to find that way. And if you don't want to join a group, a lot of people have a little different philosophy about Facebook. You don't want to join a group, you don't want to get involved with all that stuff, that's perfectly fine. Still feel free to come join us and learn and ask questions and everything you like to do. As always, we like to start off with a little bit of news from the COPD world. So we're going to take a look at actually something that isn't necessarily brand new, but has popped up in our group through the last week. And I promised one of our group members we would take a look at it today. And that is the concept of what's called targeted lung denervation, where basically you're going in, or they're going in, this isn't something you're going to want to try at home. They go in with a bronchoscope, and they have basically a very fancy tip on the bronchoscope that can heat up and actually kill off some of the nerve tissue there. Basically what the concept of it is much like a bronchodilator like Spiriva or ipratropium or Atrovent, something like that. Uses the parasympathetic nervous system to open up, to cause some of the airways to relax and open up. This lung denervation kind of works the same way, except is more of a permanent fix. By disabling those nerves, it actually forces the airways, in theory, to relax a little bit more and gain some of that bronchodilation effect. So there was a study done a couple of years ago. It was published in 2015 in a British journal called Thorax, part of the one of the main British medical journals. You can, if you're really interested in some of the deep dive into it, you can follow that link below there, and you can get some more information. But basically, the way this study shook out was that they looked at moderate to severe people, people with the older spirometrically diagnosed moderate to severe COPD, who had a history of responding of at least 15% with their FEV1 to Spiriva, tiotropium. They also had to have at least 10 pack years of a smoking history, which is 1 pack a day it's the number of packs per day times the number of years is how we figure out pack year history. But they also had to be a non-smoker for at least 6 months before the trial started, and commit, of course, to not smoking while they're going through this process. They had to have no previous lung transplant or any of the other the bronchoscopic interventions, the valves, coils, that sort of thing. They didn't want to have any kind of thoracic surgery going on. They didn't want to have anybody with recurrent infections or anything like that. They excluded people with pulmonary hypertension and a handful of other things. Basically, this was kind of a preliminary study to see if the concept actually worked. This wasn't really necessarily designed for overall efficacy or a broad scale trial or anything like that. This was kind of a more or less a proof of concept sort of thing, to make sure that this actually did work. And what they found was of the 21 people that went through, if I read the study correctly, 20 of them had no decrease in their FEV1 after 365 days after their procedure. They wanted to look at a year-over-year kind of change. As we know, many people with COPD do have kind of at least some degree of progressive decline. Everything kind of gets worse year over year. Different people go at different rates, of course, but that is kind of the theory. So they found that most of the people who had this intervention had no decrease. They didn't necessarily get better, but they had none of that progressive decline. They found that actually most of the people, their FEV1 and their FVC did actually improve to a statistically significant degree. And perhaps more importantly, both their exercise tolerance using a cycle ergometer, one of those hand pedaling kind of things, improved particularly after 180 days. They did lose some of that benefit over the course of the rest of the year, but again, they did not go below that baseline. They had no decline year to year. And their St. George's Respiratory Questionnaire, which is a measure of quality of life and symptom burden in people, again improved. It had significant improvement at the 6-month point, but was still improved over the baseline even a year later. So again, this wasn't necessarily a thing where it was completely life-altering or anything like that, but there were some significant improvements clinically and subjectively, definitely at the 6-month point, and certainly in many of these endpoints over the course of the entire year. They also found in certain individuals in this population, even though they had already kind of disabled a lot of those that parasympathetic nerve tissue, they also found that the use of Atrovent, ipratropium bromide, in conjunction with this denervation, also had some improvements. So it was kind of what they call a synergistic effect, where both of them together had a little bit more effect than either one of them had individually. So again, this was a fairly limited trial. So it was very early on in the process. But it's an interesting alternative to medications and for long-term development in treatment. This study was published in 2015, so we should be seeing some more results. I believe some more trials are underway right now. You can go to clinicaltrials.gov to see if there's one listed in the U.S., but this is something that's being looked at internationally, and has some potential for another one of those non-medication kind of surgical interventions to at least slow down that decline, that loss of lung function over time. So our other big news story of the week was a study that was published in the International Journal of COPD, and again, you can get that link down below. This one sort of ties in with our topic of the day, as we'll see in a little bit here. This study was about factors associated with appropriate inhaler use in the setting of COPD. Lessons from a study that was the real life experience and accuracy of inhaler use, or REAL study. This was a telephone study that had 23 questions, looked to be an international audience. These 23 questions covered all kinds of topics in the world of COPD, from a person's knowledge about their technique, how often they were using their inhalers, the particular device that they were using, how easy that device was to use, all kinds of stuff like that. They studied 764 people to try to figure out exactly what the state of inhaled medications was, and what they found actually some very interesting results. One of the things that really stuck out as very interesting to me was that they found that self-reported adherence to the medication plan, or what people were admitting to, was actually much lower in younger people than it was the older end of the population. So it's kind of one of those, it turns out you can teach old dogs new tricks sort of thing. They weren't necessarily clear about whether this was older people they didn't touch on the reasons why the older part of the population might be more adherent to the medication plan. Could be that they had more heavier disease burden and wanted to get more relief. They didn't feel that maybe the younger people didn't feel like the medications were doing as well because they weren't as severe. Didn't really go into a lot of detail in that regard, but I did find that factoid fairly interesting. One thing that was fairly concerning to me was that a good 30% of the study population had not had their inhaler, their device adherence measured in 2 years at least, in at least 2 years. That's something that I feel fairly strongly about, and it's something we do on a very regular basis here in our clinic. I look at people's technique at virtually every encounter. Most of the people I see on a monthly basis, particularly until we get their medication plan optimized. And I check their adherence, whatever device it is. I take a look. I have them either demonstrate to me what how their technique is. I use this device called an in-check dial. which tells me how somebody is inhaling, gives me an idea of their inspiratory flow and whether they're able to actually use the device as we're able to do. And then I just got this week a brand new device that I'm very excited about called an aerosol inhalation monitor made by a company called Vitalegraph. I have no affiliation with Vitalegraph. They have not. I actually had to pay for this device. This isn't something they provided for free, so there's no bias or anything like that. And to be 100% honest, I have only used this in the setting of a conference. I got it this week once it finally got through our biomed process where they evaluated the machines and all that stuff. I haven't actually gotten a chance to play with it hands-on, but this device is intended to kind of give us a better example, a better demonstration of timing and things like that, so that it's a more accurate look inside somebody's inhaler technique. So that's going to be a very valuable part of our practice, and it's unfortunate that 30% of this particular study population has not had that kind of experience. They did find, the last thing that they found was a couple of different inhalers were easier to use than others, as you might expect. The device they found to be the easiest to use was one called the BreezeHaler, which unfortunately is no longer available here in the United States. It was used with a medication called Foradil or Formoterol. And it was very nice. It was a very nice little device. I used to use them all the time at one of my previous jobs. It's a dry powder inhaler. It's one of the kind that you put the capsule in and pierce the capsule and all that stuff. But it was very easy to use. It was very consistent, very dependable, and borne out by this study, fairly easy to use. The device that was found to promote medication adherence, number 2, the second place device, was our trusty Respimat, which is a pretty good device. It can be a little bit tough if you have difficulty with your hands or things like that, but I've been pleasantly surprised at how little an issue that has been. When it first came out, I thought it was going to be kind of a big deal, but it's not too bad. Device number 3 was the Ellipta device for medications like Incruz and the new Trelegy. And then last but not least is this device used with Tudorza, known domestically as the Press Air. In other places it's called the Genuair, but it is found to be a pretty good device. This is one of those multi-dose dry powder inhalers where everything is enclosed and you basically just push the button to get it ready and inhale to get all the powder out. So fairly straightforward for those who can use it, but definitely make sure that if your provider has not checked your inhaler technique in a while, make sure you're talking to them about it. This is a very critical part of COPD management. And so that kind of wraps up our news for the day here, and that leads us into our main lecture for the day, which as you can tell by the name of the video here, is called Do Not Do. Now this may sound like kind of a strange title. A lot of people can pick up on that and say, well, why are you scolding me? Why are you telling me not to do something? But what I'll tell you is that most of this is actually targeted to clinicians. The whole concept of this particular video came out of a news article we saw a couple weeks ago here on COPD Navigator Live. Again, something from the International Journal of COPD, where there was an expert consensus statement called Do Not Do in COPD, a consensus statement on overuse. Now, the concept of overuse is a little bit controversial in medicine these days, especially depending on what country you go to. Of course, we're always trying to save costs and keep things down and make sure we're following our best practices and that sort of thing, because cost is obviously a big component of overuse. We don't want to be just throwing resources at stuff that isn't indicated. In addition, the more stuff you do with people, or the more stuff you do with people, the higher likelihood there is for an error. You know, whether it's testing, whether it's teaching about a particular device, whatever it is, when you have more engagement, you have the higher likelihood for error. That's just part of human nature. You also tend to have no particular added value. It's kind of like if you have a glass full of water and you try to put more water in it, you're not really getting any more benefit from that. It's already full. So when we're doing the things that are clinically indicated for people, we can't really improve on that just by doing more stuff. as much as we might like to. And of course, it reduces efficiency throughout the healthcare system. When you have people, when we're trying to do too many tests, we're scheduling too many tests, we're taking up too much time at the testing centers for people who could actually use some of that stuff and benefit from it. So what happened was, this study group in Spain, the working group of a working group of the Madrid Society for Pulmonology and Thoracic Surgery, which was comprised of 6 pulmonologists, 2 general practitioners, kind of the equivalent of our primary care providers, 1 nurse, and 1 physiotherapist, which is sort of the international equivalent to a respiratory therapist. As I understand it, scopes of practice are a little bit different. They're maybe more akin to more of a physician's assistant than just our traditional respiratory therapist, but sort of the equivalent type of concept. That whole working group came together, and first it was by remote, and then they came up with 157 different particular domains, questions that they thought, things that were out there that they thought might be overused or might benefit from a review process. They scored those based on whether there was consensus about yay or nay in a particular domain. Narrowed that down to 95 in the first round. Then of those 95 different criteria, they looked for overlaps. They looked for whether there was consensus in the group about how important it was. Winnowed that down further, almost in half, down to 55. And where they all came together to have a conference over a couple of days to discuss it even in more detail, sort of like the town hall we had in COPD a couple years ago, and took that group of 55 and narrowed it down to 16 final recommendations, which form the foundation of this journal article. And those 16 are what we're going to talk about today. They broke them further down into, there were 6 that were for stable management of COPD. I think there were another 6, if my math is right. Yeah, 6 for the treatment of acute exacerbations, and then the last 4 were specifically targeted to how people can better care for themselves, improve self-management, self-efficacy in the management of their COPD cases. So without further ado, let's take a look. And oops, that's the wrong button. Number 1 is, let's see which shoulder, that's going to be on this shoulder. Do not administer inhaled corticosteroids routinely for people with an FEV1 greater than 60% of their predicted value and with 2 or fewer exacerbations, unless they have that sort of asthma COPD overlap syndrome, which we can spend another whole hour talking about that. So this is kind of an ungainly recommendation, so let's break it down a little bit more. We know that the Global Initiative for Chronic Obstructive Lung Disease, or GOLD, a couple of years ago now came out with a recommendation that we're starting to move away from using these inhaled corticosteroids as kind of routine care, because we do find that while they work great in asthma, because you tend to have a lot more inflammation and that sort of thing in asthma, they do tend to have a little bit less benefit in the COPD population, and unfortunately they can also raise your risk of pneumonia. Depending on what study you look at, there's some controversy as to how much it increases your risk, but all things considered, even in general, we do like to try to avoid using steroids, whether they're inhaled or oral or systemic, whatever we want to do. We are trying to get away from those a little bit more, and so this is kind of a first step in trying to target a particular audience for who we should be using those things are. So we need to look at if you have an FEV1 of 60% or more, traditionally you have been considered to have relatively mild to moderate COPD and probably wouldn't benefit so much from these inhaled corticosteroids, certainly not enough to justify that risk. Also, if you have relatively few exacerbations, you have, even under the newer scoring systems, you have relatively mild COPD with low risk of exacerbation in the future. The more exacerbations you have, the higher your risk, so the fewer you have, the lower the risk. And so we don't necessarily want to use inhaled corticosteroids in that population, even though that has traditionally been our standard of care. We want to try to look where the evidence is taking us, and this is where the evidence is taking us. Now, of course, we do have that disclaimer, except for asthma COPD overlap syndrome, which again, as I said, is somewhat ill-defined. We don't necessarily have a great idea of what's going on with that. But for those people who have a reactive kind of airway, we will want to continue to use, or who we can diagnose with airway inflammation if we do what we call an exhaled nitric oxide study and we see evidence of inflammation, then those are the people that we're going to want to target that inhaled corticosteroid use for. But in everybody else, it's probably a little bit overused and we should probably not be doing it anymore. So, of course, when we want to target that FEV1 criteria, we need to also look at spirometry. And so our next do not do maybe sounds a little bit backwards, but it's do not neglect it's basically do not do spirometry when you have risk factors present. Now, screening spirometry in particular has been a little bit controversial. A few years back, the United States Preventative Services Task Force actually found that we don't necessarily want to do spirometry screening on everybody. When we use spirometry, or when we use screening in this sense, we use it in the sense of every time you go to your doctor's office or your nurse practitioner's office, whoever it might be, every time you go see a provider, you usually get your blood pressure taken. You usually get a couple of those things done all the time. That is what we consider screening, something that we do for everybody out there to try to find those people who are suffering from a particular condition. What we found was, because of the costs involved with spirometry, because of the risks of false positives, because of a lot of other, the time, the opportunity costs are called, the time to make an appointment, all that sort of thing, it wasn't necessarily worthwhile to just do spirometry willy-nilly on everybody. However, we have found through the use of screening techniques, and there's a new survey out there that I always like to point out because I love what they did with the name here. This was a study that came out a couple of years ago. They found this 5-question questionnaire called the COPD Assessment in Primary Care to Identify Undiagnosed Respiratory Disease and Exacerbation Risk. Took all those words and manipulated them enough to just get the acronym CAPTURE out of it. I always get a kick out of that, so I always like to throw that out there. This capture tool, which unfortunately I don't have a copy of right now, like I said, it's got a couple of questions on there about your smoking history, about your symptoms and that sort of thing. Sometimes we throw a peak flow measurement on there. We try to figure out exactly what people are at relatively high risk for COPD. And then that's the population we do spirometry on. Those are the people, if you have a risk factor for COPD, that's who we want to target with our spirometry and send for more intensive testing. But no matter what it is, when we have risk factors present, we definitely want to make sure that we are not forgetting to do spirometry. Now, this kind of ties in. I think this is probably one they could have winnowed down even more and gone down to 15, because the next do not do was actually do not initiate treatment without confirming spirometry. To me, these two elements kind of overlap with each other. We want to not forget to do spirometry, and if we're not forgetting to do spirometry, then we're surely not starting to treat anybody without spirometry, but they chose to keep these separate. I guess that's why I'm not on the expert panel. But regardless, whatever we want to do, we want to make sure before we just label somebody as having COPD and start them on a path and do all that, the charting and all that stuff, we want to make sure we're treating the right condition. This is something I have seen a lot here in the office. We've got people who it's kind of an assumed COPD. We have a lot of diagnostic problems with that. We want to make sure that when we tell somebody that you have COPD, you probably have COPD, and so on and so forth, that we know what we're talking about. In order to know what we're talking about, we've got to do spirometry. Now, this next one here also ties in with our news of the day. Do not assume people are using their inhalers correctly without actually checking it. You'll think back when we talked about that one study, we found that 30% of people on inhalers and stuff have not had proper evaluation in at least 2 years. We cannot, as clinicians, assume that people are just using their stuff correctly. I had a person the other day who they've been on the relatively new dry powder form of the generic Advair. Didn't feel like they were getting a lot of benefit from it. We did we used the inject, and we saw that, well, you don't seem like you're getting a lot of inspiratory flow through there. Is this little meter on the back of it, the dry powder, the new generic Advair has a dose counter on the back. Is that changing every time you use your inhaler? And she said, no, it's not. It's not changing at all. I rarely get it to change, especially if I'm having a bad breathing day. Unfortunately, because we don't routinely evaluate somebody's inhaler technique, we're missing a lot of that stuff. We're missing opportunities to improve people's quality of life. We're missing opportunities to optimize treatment. We cannot, as clinicians, and if you're clinician, I'm saying this to people with COPD who are watching, if your clinician is assuming that you know how to use your device, then you can go wag your finger at them, and you can tell them, why haven't you checked my abilities? Why haven't you checked my ability to use this? Why haven't you checked my knowledge? Is this the right device for me? We had a discussion in the group the other night about kind of an unrelated topic, but if I can soapbox for a minute here, it's my personal belief that as a society here in the U.S., we tend to get wrapped up in, well, my provider told me so that's what I'm doing, and we have this almost parental relationship between people and their providers, and what I like to see is much more of a team effort. And in order to do that, we have to make people feel comfortable to ask questions. And so I've talked about this before, my first encounters with a lot of people, I spend most of that time just trying to build trust, trying to make them feel comfortable so that I can help with any kind of barriers that they have. Everybody wants to be the good patient, myself included. I've told a few white lies here and there going to my provider offices. Everybody wants to be, oh yeah, I'm using my stuff, I'm using it every day, I'm using it as appropriate. But we can't assume that anymore, because if we want to make sure that people are getting the right care, we need to be evaluating how we're teaching, how people are learning, and making sure that they're using the right devices for them. Along those same lines, we want to make sure that we are not changing someone's therapy without evaluating their adherence to the plan first. Now, what this means is, and I'll walk you through an example that we do here at our clinic. When I see somebody, especially for the very first time, with COPD, particularly if we've gone through the spirometry and all that stuff, I use what's called the COPD assessment test, which is an excellent tool. It is a proprietary tool, so I will also disclaim that I am not connected with GlaxoSmithKline, the makers of the study or of this test in any way. It is a fairly validated tool. So what we do, so that's why I use it. And it's a lot shorter than that St. George's questionnaire that we mentioned in one of the other studies. What this is this gives us 8 questions ranging from everything, talking about everything from your cough to chest tightness to your sleep, your energy level, all that stuff. And what that does is that gives me a score, and that tells me exactly how you feel about the burden of those symptoms on your life. And so at follow-up meetings, at my monthly follow-up meetings, we do that same test over again, because I can't figure out if things are going in the right direction unless I have some kind of score. Sometimes I also make sure to ask how people feel about their care and whether they're feeling better or not, but it's good to have some evidence when we're making an adjustment. Now, let's say we put somebody on a new inhaler at that first appointment, and at their next appointment, we haven't seen any change in their CAT score, their CAT score. Does that mean that inhaler didn't work? We can't necessarily make that assumption, even though we often do, and that's kind of what this is talking about here. We can't assume that treatment has failed without evaluating how that person is taking their inhaler or their other medication. Maybe they weren't able to get their inhaler until 2 days before the appointment. This has been ongoing. This has happened a couple of times with controller medications like Spiriva, or even things like in combination inhalers like Symbicort, Dulera, that sort of thing. A lot of those medications take time to work. That's why I don't see people for a month. Spiriva, for example, takes a good 7 to 10 days. Some people it even takes up to 2 weeks. Can take up to 2 weeks to make sure that to get to a level where it's actually functioning inside your body. So if somebody's only been on it for 2 days, they haven't been adhering to the plan, so we wouldn't expect to see that kind of improvement. Now, if we go look and we see somebody went out right after the appointment, got their inhaler, has been taking it properly, has been taking it every day as directed, and we still haven't seen improvement, then we know that the person has adhered to their plan and the fault is with the plan itself. So we can't just assume, we can't just go changing therapy unless we have evidence that that therapy has in fact failed. Next up for bids is do not do serial pulmonary function tests at every encounter without changes in symptoms, without changes in a treatment plan, or changes in exacerbation frequency. This is probably kind of a controversial idea. Serial pulmonary function testing, serial spirometry, has been kind of a hallmark of COPD care for a long time. That's how we track decline, that's how we track progression, all that kind of stuff, especially as we have relied heavily in the past on spirometry-based severity staging. As we have moved more toward symptom-based severity staging, we're getting a little bit away from some of that stuff. Now, I always, and GOLD, if you look at the GOLD recommendations now, they basically say once you do spirometry for diagnosis, you don't really need to do spirometry ever again. Now, I kind of fall not quite that severe. I look at it as I like to do spirometry somewhat regularly, maybe once a year or something like that, because if there are unusual changes, we might need to look at, and maybe we need to pick up something else. Maybe there's something else we need to be looking at. Maybe there's an issue that has popped up. If there's an unexpected change in somebody's spirometry, we need to be evaluating that. So I'm not the all or nothing kind of guy, but we don't need to be doing spirometry once a month, once every 3 months, all that kind of frequency. That's extra burden. Many people who do pulmonary function tests will tell you that they take a lot out of you. Sometimes I have pretty normal lungs, and if I have a day full of spirometry, and because I breathe as I coach people through it, and I'm taking the breath and I'm blowing it out, it can be a workout. And so when you're already a little bit behind the 8 ball with lung disease, that's an even bigger workout. So we don't necessarily want to put people through that unless we absolutely have to, unless there has been a change in their symptom level. Maybe they're complaining of higher symptoms, and so we need to be checking that. Maybe they've been in the hospital a couple of times, and we need to be reevaluating their management plan. But we don't need to just be doing it again willy-nilly, just throwing stuff out there. Okay, so now we're talking about exacerbations. Now we start talking about how we handle acute exacerbations, symptom flares, whatever we want to call that. And the first one we want to do here, we want to look at is we don't necessarily want to do antibiotics in all cases of exacerbation. Certainly, many people with COPD, particularly on the chronic bronchitis, bronchiectasis end of things, do have kind of a chronic colonization with particular bacteria. And we want to make sure that they have the right therapy. A lot of times, if you have a chronic colonization with bacteria, you can build up more. You can be, and that's what's causing your lung infection, your pneumonia, your exacerbation, whatever is leading to that symptom flare, and that's an issue, and that's something we need to address. But there are also viral causes of pneumonia, viral causes of exacerbations. There's a lot of symptom stuff out there that aren't necessarily caused by bacteria. And of course, traditionally, we want to throw bacteria or antibiotics at anybody who's sick, and that has led us down the course of antibiotic resistance, which has led to more powerful antibiotics with more side effects that are more expensive and a lot of waste in that regard. So we don't necessarily want to just be throwing antibiotics at people, just like we don't necessarily want to be throwing anybody at anybody without some evidence to it. Also with exacerbations, we don't necessarily want to do high flow oxygen unless their pulse oximetry is less than 90%. Now, this particular paper and some of the background information didn't really go into a strict definition of what's considered high flow oxygen. In my practice, it has generally been considered something like a non-rebreather mask. That's the mask that has a little bag on it that gives you 100% oxygen or fairly close to that. There are also high flow nasal cannulas that give a lot of oxygen at a very particular percentage. I'm not entirely sure what this working group was going for when they were mentioning that, but in general, it's pretty good practice to not be over oxygenating somebody when their pulse ox is over 90% anyway, or if you happen to get a blood gas, if your PaO2 is over 60 millimeters of mercury. There's a lot of talk about the hypoxic drive, which is not necessarily a thing. A lot of people talk about, well, if you put somebody with COPD and oxygen, they're going to stop breathing. That happens very rarely, and it's usually not because your drive is dependent on being hypoxic. It's a combination of a lot of other factors. But more importantly, again, this is kind of a resource management kind of thing. This isn't something we don't necessarily want to have stuff strapped to someone's face if we don't want to. We don't necessarily want to be using equipment that we don't need to be using, and all that sort of thing. You know, a lot of times it's been the better safe than sorry. When people are having chest pain, when people are having shortness of breath, the first thing we do is throw oxygen on them. American Heart has backed off a lot on the use of their, the American Heart Association has backed off a lot on the use of oxygen for chest pain, and now we should probably be backing off with the use of oxygen unless it's indicated. Again, if you have that low pulse ox, then by all means have all the oxygen you need. But unless you're there, we don't necessarily need to be putting you on that either. Similarly, we don't necessarily want to send people home on oxygen unless they're hypoxic. This is one where we really do look at the pulse or the blood gas for this one. If you have that chronic hypoxemia, especially that more severe stages, then yes, absolutely, we want to supplement that and make sure that you are breathing as easily as possible. But it's not, again, not something we necessarily need to be throwing at everybody all the time. Another one that is near and dear to a lot of people's hearts is corticosteroids. We talked about inhaled corticosteroids before. This is more on the topic of prednisone, the pills that you get a lot of times when you have an exacerbation, or if you were watching last week's episode, we were talking about having an action plan. We don't want to have people on corticosteroids for more than 14 days, and we're also really getting away from that concept of the taper. Traditionally, it's been felt that if you have somebody on a steroid, you have to be on it for a while and then kind of gradually wean yourself off so that your adrenal system picks back up and all your hormones get back into balance and all that. We're finding more and more that the risks of prolonged exposure to corticosteroids outweigh any kind of risk of adrenal fatigue or anything like that. So we're starting to do these quicker bursts where maybe they're a little bit more intense, but for a shorter amount of time. And we're having just as solid outcomes with that. So, and in some cases, even improved outcomes if you look at, depending on what study you look at. So we don't want to have people on these steroids for a prolonged period of time because it's just causing more trouble than it's worth. Although again, that's kind of the old habits, which definitely die hard, but we need to be working on changing a lot of that stuff. Finally, for the acute phase of an exacerbation, we do not want to be doing spirometry if we already know the person has COPD. Again, this is kind of a tricky concept. We've talked a lot about, when do we do spirometry? When should we be doing spirometry? If we know somebody already, if we've done spirometry and we've already been able to confirm a diagnosis of chronic obstructive pulmonary disease, there is no reason to be doing that during an exacerbation. Again, we're putting people through flows and through efforts that aren't going to give us any actionable data. We know you have COPD. We know you have breathing problems. So what does it matter how much we quantify? Do we want to say, well, Mr. Jones, your breathing is 15% worse than it should be, or it's not really going to impact our treatment, so we don't necessarily need to be doing that. Now, again, we go back and we look at when do we do some of the serial stuff. After a few months, after somebody has recovered to their baseline, after they've recovered to a kind of a holding point or a baseline, then we're going to look at maybe doing spirometry again to see if we need to make any adjustments in their plan or anything like that. So. Side note, forgot to mention at the beginning here, we do have that question and answer period coming up here. So make sure you get your questions in either to the side or down below, wherever your screen is set up to have that comment area. And I'm going to stop here and mention Tom's question here, who asks, what if one has been on prednisone for years? Again, this isn't to say that we shouldn't ever use prednisone for any reason or anything like that. There are very definite clinical indications to have somebody on a steroid for even for a long time. There are cases where that's what's necessary to keep those symptoms at bay. But it's something you need to discuss with your clinician about whether it's the most appropriate therapy for you. It could very well be that other things have been tried, and this is what works. This is the only thing that works. And if you're not on it, then you're going to have an incredible amount of symptoms, and your lung function is going to decline, and it's going to be a big issue. But it could be that this is just kind of an old habit thing. So. The question of what if one has been on prednisone for years is unfortunately a little bit beyond the scope of this presentation, but it's definitely something you're going to want to talk to your clinician about and find out why you're on that prednisone. Again, maybe there's a very good reason, maybe it's just because, and if that's the case, then it's definitely something to ask some questions about. So we've covered the dozen or so things about management of stable COPD. We've covered the half dozen on and acute exacerbations, half dozen each. These next four are again particularly targeted at I'm going to make an assumption and say the people out there with COPD who are looking for things, better management strategies on how to improve your self-efficacy, as we like to say, or improve your self-care. And so for these, I wanted to emphasize them a little bit more. So we moved from up here down here. I want them front and center so that you can really take these lessons to heart. And the very first one, probably the most important one, don't stop taking your medications if your symptoms have improved. Again, this is one of those human nature kind of things. When you get sick, you take some cough syrup, you're on cough drops for a few days, you feel better, you stop taking the stuff. When you have a chronic disease, whether it's COPD, whether it's diabetes, high blood pressure, any of those things, if you take your medications and you're feeling better, that doesn't necessarily mean that all that stuff is gone. It means your medications are working. So we don't want you to stop taking the things that are making you feel better because you feel better. So this is a very common thing, believe it or not, in certain crowds. At least that's what the data tells us. But please do not stop taking your medications just because your symptoms have improved. Also, very important, do not use your inhaler incorrectly. And we had that whole big talk about making sure that things are checked, but make sure that you are taking your inhaler correctly, whether it's asking your clinician, whether it's watching a video from the COPD Foundation or asthma allergy people. There are a couple of different groups out there that have videos on YouTube that talk about proper inhaler use. We discuss it on some of these Navigator live videos from time to time. We're probably about due for another medication checkup, as a matter of fact. We want to make sure that you have the tools that you need to manage your disease appropriately, and in many cases that is proper use of an inhaler. So make sure you're using it correctly, make sure you're not using it incorrectly, make sure that if you don't know if you're using it correctly or not, make sure you ask. Please never be afraid to ask. These things are complicated. I mean, it has a far different inhalation technique than this, which have different inhalation techniques than a regular meter dose inhaler. And so it's hard to keep all that stuff straight sometimes. Do I breathe fast? Do I breathe slow? So on and so forth. Make sure you know how to use this stuff. Make sure you're using it appropriately, and make sure you don't hesitate to ask if you're not sure. Next up, do not stop walking because of dyspnea or shortness of breath. I know this is easy for me to say. I don't necessarily feel that unless I've been puffing away on the elliptical for a while. But exercise is other than quitting smoking, that's number one. But exercise is the single most important thing you can do to help improve your symptom burden. Cardiovascular exercise helps your metabolism work a little bit better. Resistance training helps build up your muscle mass, helps your body use oxygen more efficiently, can help build up your rib cage and all that kind of stuff and make sure that's working a little bit more effectively. But make sure that you're walking, moving, biking, pedaling with your arms, whatever exercise plan you have, make sure you're following through with that and not stopping just because you feel short of breath. Try to push through that. If you are having trouble, make sure you talk to your clinician about pulmonary rehabilitation. Make sure you talk about exercises that you can do. Make sure that you're doing an exercise plan, a plan that's appropriate for your state. But do something. And last but certainly not least, we want to talk about do not take unprescribed medications. Now, I'll put a little caveat on here and say do not take unprescribed medications without talking to your clinician. There's a lot of stuff out there that is over the counter that may help. One of the biggest things, I think we talked about this a couple of weeks ago, is a supplement called acetylcysteine, N-acetylcysteine. It's a supplement you can get from vitamin stores, health food stores, that kind of thing. There is some very preliminary data out there that talks about it decreasing exacerbation frequency, bringing down some of those inflammatory markers a little bit. Not something that gets prescribed, so I don't necessarily want to throw that out with the bathwater, but make sure that you're letting your clinician know anything that you're taking that they haven't prescribed. There are certain interactions out there we need to be mindful of. There's a lot of stuff that can be helpful when coordinated properly. We always want to make sure everybody is on the same page with a lot of this stuff. We want to make sure that everybody is rowing in the same direction and coordinating with each other so that you can get your best breathing, your best symptom control, and everything else going on. When they say don't take unprescribed medications, we're usually looking at stuff. There's a lot of snake oil out there. There's a lot of unscrupulous people who are willing to take your money for things that are of dubious value. And there's a lot of confusion out there, frankly, about what actually will work. So just make sure you're touching base with your clinician and doing the best thing for you and under the guidance of science. So with that, I know that was a lot to take in today. That is kind of our list of things to not do with COPD. A lot of things that have traditionally been standards of care that maybe aren't necessarily. Now there are a couple of caveats to this. First of all, the authors were quick to point out that this was basically because it was the Madrid Society of Pulmonology and what have you. Their results may be localized to Spain. Personally, I think that they're pretty. They translate pretty well all over the world. This is some pretty basic stuff, but that is something that they wanted to be mindful of. They haven't included a lot of these measures in quality surveys and stuff like that, so there hasn't been a lot of objective data that says, well, when we have stopped doing this, we've saved X amount of dollars, or we've reduced exacerbations, or whatever. So their key takeaway was that this is expert opinion rather than a randomized study or anything like that, which is the highest thing available. But this is science-backed stuff. This is expert opinion. I mean, these people are experts for a reason. You go down the list and you see names like Alvar Agusti, who's part of Gold. You see Barcelli. You see some of the giants of the field. These people know what they're talking about, and they would be who I would want caring for me. So it's only expert opinion, but it's expert opinion. It's also very similar to a lot of other recommendations that have come out by groups like the American Thoracic Society, American College of Chest Physicians, also looking to optimize care, optimize treatment, and that sort of thing. So while it's not a randomized trial, it's probably as close as we can get for a lot of this stuff, and it's certainly stuff to be mindful of. So with that said, that is the end of our lecture for today. Happy to take some questions here. Some other questions. First off, of course, I want to go back through some of the list here. Appreciate everybody stopping by, everybody saying hello. I want to go back and talk with Robin here. For 2 years, my oxygen has run 94 to 95. The last couple of days, 97, 98 oxygen at night. Is this normal to see at times? And I would say yes, actually it is. Again, we're probably due for an oxygen talk again before too long here, but if we look at how oxygen works in the body, very oversimplified right now, but there's about yay much clinical difference between 97 and 92, even 99, 92, you know, the high end and the low end. Now, once we get to that low end and we start hitting that 92 and a little bit lower mark, things get worse much faster. It's this, we call it the oxyhemoglobin dissociation curve, basically. It's very similar. That talks about how oxygen sticks to the blood, but it's also pretty relevant to how quickly things can change. When things are in the 90s, not so bad. Once things hit about 90 to 92, then they start making this curve, and once you get under 90, things get worse in a hurry. So I certainly wouldn't fret too much about going from 94 to 95 to 97, 98. That's probably some normal variation. Depending on how long it's been since your nocturnal oxygen has been evaluated, all that stuff. You mentioned you're on oxygen at night. Might be time for another overnight oximetry or something like that to make sure you're on the right plan, but probably pretty normal and probably not much to worry about. Linda mentions no one has ever gone over inhalers or the proper way or in which order. Unfortunately, we don't have a lot of data on the best order. There is a lot of the older school of thought is we want to use the quick acting stuff like regular albuterol to kind of open up some of those airways and let some of the controllers penetrate deeper. There's another school of thought that has a lot of compelling rationale behind it. It says use the controllers first so that we tie up those receptors and we're not wasting them on stuff that's not going to last. But we don't really have a lot of studies to do the order. Technique, we do have studies. We do know the proper technique and stuff like that, and I'm sorry that no one has taken the time to do that with you through pharmacy, through your clinicians, or anybody. That is definitely something we're going to look at in our next set of videos coming up. I think we're full up for March, but we're going to take a look once we get through into April. We're going to do some of the review sessions again, and we'll talk about some of the techniques, especially once I get learning how to play with this thing a little bit more. The inhalation monitor, I'm excited to learn how to do that, and we'll get you trained up. Pam, when you have time, could you post a link to the study in the group? Absolutely. Let's see, I actually have a link right there. We will copy that, and if all goes well, we'll get that pasted right to, oops. On Facebook, of course, can't make anything quite as easy as we want it to be, but that should work okay. Yep, there we go. There's a link popping up with the preview. That is a link to the study where you can print that, save that, what have you, to for your own reference for moving on in the future here, and hopefully that will help. So Tom again mentions, do inoperable hernias make it difficult to exercise? Yes, I would say that they would. Of course, depending on the type of hernia and all that stuff, there are still a lot of things that you can do. But of course, whenever you have any kind of muscle weakness or anomaly like that, especially in your core, that's going to make it much more challenging to do a lot of exercises, because it's one of those things that we don't really realize how much impacts our movement and all that stuff until there's some kind of damage or some kind of issue. So it certainly can make things a lot more difficult, more painful, can make things more challenging, make things less comfortable, all that kind of stuff. So definitely that is a factor. If you do have things like inoperable hernias, you're going to want to make sure that you're checking with your clinician and coordinating even more, not just with medications, but also with exercises and activity plans and that sort of thing. So we are getting a little bit short on time. We can probably take another question or two here. So if you have anything on your mind, doesn't have to necessarily be due or be about do not do or anything like that, or anything we talked about today. We'll get those in. Again, for those of you who might be new to the program, we do this every Friday, usually around noontime Eastern, here on Facebook Live. We will be getting this hopefully up. We're doing a little bit better at getting these archived on the YouTube these days. That will happen next week sometime, so if you happen to miss this, or if you're catching this on tape delay, make sure that you stay tuned for further updates and new episodes coming up here. I'm going to take a look real quick and see if I can figure out, usually I try to write it down, but I forgot what our next week's episode is. So we're going to take a look at, while you all are trying to figure out if you have any questions coming up. If I can click on the right thing here, I guess I'm going to have to go to a different area. Also want hope that everybody's weather is cooperating. We had a flash of snow here in Michigan again, which was unfortunate, but it's kind of all melted again here. Okay. Next week we're going to be talking about COPD Mythbusters. This is another one that's kind of inspired by an article I saw. This was in a special supplement to Time magazine, one of those things that you find at the doctor's office every now and then. And it had a certain list of myths about COPD. Some of this stuff is probably going to be a little bit of a review of what we talked about today, but there are some important other things out there. We're going to be talking about myths and things that may be true, things that maybe aren't so true. So if you have heard things about COPD and you're kind of curious about whether that's a myth or reality, make sure that you submit that to COPD Navigator, either our Facebook page, or if you're a member of our group, you can go ahead and submit that there. You can comment on this video. I'll check the YouTube comments too. Make sure we get your myths covered as well. Thank you, Pam. Appreciate that. I don't know if best ever, but hopefully things. We only had one glitch this week, which was kind of one tech issue this week. Everything else looked on this end, at least, to be going pretty smoothly. This was one of my favorite topics to prepare for. Actually, I thought this was really interesting to review a lot of this stuff and see how it went. So I very much appreciate you saying that. Julie, I am physically located in Michigan, in southwestern Michigan, in Kalamazoo specifically. In the internet world, you can usually find me pretty much a lot of different places. On Facebook, we're at COPD Navigator /groups, or facebook.com/groups/COPD Navigator. Also just started a Facebook page to make things a little bit easier, so you can link up that stuff, and that's where we're at. Tom, appreciate you stopping by. First time member, first time visitor. Hopefully we'll be able to see you again in the future. And again, of course, if anybody has any questions, anybody has concerns, anything like that, please feel free to let us know. Love working with the COPD community. Very much appreciate everybody who has welcomed me in. And it's been great to do a lot of this stuff, and great to learn from many of you in the community. In COPD Navigator, we have many people who are at lots of different stages. We've got people who are waiting for transplants. We've got a couple people who have, we've got one in particular who has just received a transplant. Looks like Bonnie was able to join us again this week. We've had a lot of experience. Everybody is very willing to share their knowledge, share their experience, share their tips and tricks. We've got myself, we've got a couple other respiratory therapists, pulmonary rehab specialists. We've got a great group of people, a fantastic community. I really appreciate everybody stopping by today. Hope you have a great weekend. Take care of yourselves, take care of each other, and we'll see you next week for COPD Navigator Live Mythbusters. So take care, everybody.